for say 6 months, they complained of constant pain in squatting.
Good morning, everyone. I'll be speaking on a prospective study of anterior cruciate ligament reconstruction using 4 standard hamstring grafts. Coming to the introduction, ACL injury is quite a common injury with around more than 2 lakh cases, of which 1 lakh undergo reconstruction in the United States, and majority of ACL injuries there occur due to sport activities, high agility sports and like soccer, basketball. Although there has been no study done in India, but there has been an exponential rise in India, mainly because of the road traffic accident and increasing sport activities now. ACL deficient knees have a disabling anterior distant loss and instability, resulting in meniscal tears, chondral injuries and osteoarthritis. The present autograft choices which we have are the hamstring grafts, BPTB grafts and the quadriceps graft. This has been the evolution of graft choices done in Sports Medical Clinic IOACON. Initially in 1990s, BPTB was the preferred graft, but later on the semitendinous graft has been increasing. The hamstring grafts are often selected because of smaller incision over the knee, which is cosmetically acceptable. Graft donor site mobility is less, and the main important thing of anterior knee pain is very less in hamstring grafts. The patelloquadriceps mechanism is not disturbed, and the strength of the hamstring graft is the 4 standard is more than any other type of grafts. Our study was a prospective study in which 64 patients were included at Hospital Bangalore, and 1 year follow-up was done. 27 were males, 37 were females. The inclusion criteria included symptomatic ACL insufficiency, injury occurring more than 1 month before the reconstruction, no previous reconstruction of ACL, no PCL insufficiency, and mainly the instability during activities of daily living. Exclusion criteria was any other ligament injuries or fractures of the ipsilateral side and any acute anterior cruciate tear. This was the surgical technique. Sartorius fascia was incised, graft was harvested. The plica was removed, and using a graft harvester, the graft was harvested. The preparation of the graft, sizing of the graft, the drilling and fixation of the graft with bioscrews. We did the functional scoring using LISCOM scores and IKDC scoring, and used an accelerated rehab protocol, especially in the first week itself, and even the first day itself. We started the knee range of movements with 50% weight bearing. For the first week, as the patient moved on second week, we started 75% weight bearing, and full weight bearing was started at the end of 3 weeks. Light jogging was started at the end of 12 weeks, and contact sports were avoided for at least 6 months. The results, we have males 27, females 37. Road traffic accident was the major concern in Indian patients. Around 54 patients had road traffic accident injuries. Meniscal injuries were 10, 16 in lateral and medial, and both were injured in 12 patients. The 64 patients were evaluated at the end of 4 weeks, 24 weeks and 1 year, and patients were evaluated using a KT arthrometer for laxity, range of movements and functional outcome using LISCOM and IKDC scores. As come LISCOM scores, we got excellent results. 56 and 34 patients as excellent and good. 10 patients had around less results, and IKDC scores 72% of patients attained pre-injury activity levels. 24 patients were better than pre-operative but not to pre-injury levels, and 4% reported no improvements. And mean range of movement was around 0 to 130 degrees, and only 2 patients had laxity more than 3 millimeter after a year of follow-up. This was compared with other scores which depict the same pattern. Coming to discussion, despite a good knee stability, some patients, especially the Indian patients, however, hesitant to unduly stress the knee. Even if they had completely normal knees, they were hesitant to do any heavy activities or sports activities. Patients with excellent to good results described their knee as completely normal. Of the 3 patients, we had 3 patients were sports person. 2 of them returned to normal sporting activities after 9 months follow-up. 1 chose not to pursue competitive sports. Patients with extensor lag or incomplete flexion were not totally happy with the results. This is just a general follow-up. Avoid graft rupture while harvesting, graft angle mismatch, educate tension, isometric impingement-free location, and avoid a blowout. Another thing we found that IKDC scoring is actually not appropriate for measuring the functional outcome in Indian scenario, where people are often defer undergoing rigorous activities of in daily living or playing high pivoting sports, in which IKDC scores give a high value for these activities. Complication, we had 1 patient with superficial infection at the incision site, which was completely resolved with antibiotics. 1 patient had deep infection for which lavage was done, and However, the functional recovery was attained in this patient. Two patients had pain over the hamstring side. No anterior knee pain was noted, which also settled. Two patients had persistent instability, which was present during the increased level of activity, and one patient had stiffness because he did not comply to a physiotherapy protocol. He came to us after a month, after which the range of movement of the knee was started. So in conclusion, ACL reconstruction using 4-stranded hamstring grafts gives excellent results with very few complications and can be the graft of choice, especially in Indian scenario, where people are less hesitant to undergo very rigorous high activities of daily living. Thank you.
Questions, please.
Two questions.
Yes, sir.
Very common complaint that I have faced after hamstring graft is the persistent hypoesthesia over the anterior aspect of the
Yes,
issue,
sir.
which I think you have not mentioned.
Yeah.
Secondly, in a 4-stranded graft, normally what I feel is it comes out to be a very long graft, and usually the diameter is 8 or sometimes even 7.
Yes, sir.
So is there any experience in your institution regarding taking triple semitendinosus graft or maybe quadruple semitendinosus with a 2-strand grafts, like a 6-strand graft?
No, sir. We generally prefer 4-stranded grafts. For this study especially, we have done only a 4-stranded graft.
So yeah, any your comments regarding this thing?
You are very right that graft looks very weak.
Very weak. It's
When with a big knee in a young male. So I always make the half of the semity and quadruple it, and one strand by the grassless I get, that I just loop it. So that gives me 9 plus
9 plus.
most of the time.
That's a 6-stranded graft.
Yeah, and length of 70 around, that I always get when I use it. And if we put 20, 25 on either side, then it comes to be an adequate one if you want to do it, and it hardly ever fails. And the other thing, hypoesthesia is a real problem, and we don't have any explanation to that, whatever nerve injury it is said to be. But over the time, people are used to it, or it disappears a little bit. It's a usual complaint, and I just want to ask from you, whatever you have talked is the standard thing that everybody is doing, and the results are also the same one. What is the proper tensioning of the graft, you said, and what is the position at which you tighten the graft at the time of fixation?
At the time of fixation, for the around 20 to 30 degrees flexion of the knee, with studies have shown that increasing the tensioning of the hamstring graft will actually result in lesser functional outcome. So if we decrease the tension, they give better results as for the hamstring grafts.
And that's what I am asking, what is that adequate tension you used in your study? You said we give adequate tension at the time of
Yes, sir.
fixation.
So there is no as a measurement we have done, but
what you followed, that's what I want to ask.
decreasing the while tensioning the graft, we can decrease it.
Anyway, I have just to mention one thing, that when we tension, then we pull that much that we are pulling the patient, just moving the patient, and at the same time some people are trying doing the posterior drawer at the time of tensioning. So that sometimes gives you anterior pain and the grating of the patella. So what I have started doing, that I have stopped at least doing that posterior drawer at the time of fixing on the tibial side. So Dr. Arun, any idea?
Regarding tensioning, earlier the grafts were used to be pre-tensioned.
Pre-tension.
Then the studies came over that there's no help out of that pre-tensioning. So you can tension it, cycle it, once you put the graft, fix it on the femoral side, and then tension it with adequate tension. So there's no parameter. There are certain instruments which can give you this much Newton of force you are applying to the tendon while fixing it. But the pendulum is swinging towards the gentle tensioning, not a very aggressive tensioning as far as the soft tissue grafts are concerned. More so it is important for a bone patellar tendon graft, because that is more prone for stiffness rather than the hamstring graft. And a quick note for the hypoesthesia or paresthesia on the nerve, that those who are doing it on a regular basis, the nerve is just medial to the sartorius, and at times it is quite thick, just half the diameter of the gracilis, which is again just medial to that nerve. So try to look and find out in each and every case. Probably you will succeed in 60% of case to look at that nerve and hook it with that any kind of right angle mosquito or forceps or a Langenbeck retractor, and then harvest the gracilis tendon. Or, yeah.
I did find the nerve in some of the cases, but while trying to harvest the graft, most of the time it got after locating it's very difficult because it's a very narrow space, and
Yeah.
probably you are doing a
Yeah, I'm doing from the posteromedial side, and I just, almost in all cases now, I can identify the nerve with small veiny committents with it, and you just retract it gently, and then you can harvest with open stripper. If you're harvesting from the anterior side, the more conventional side, then probably do a more blunt dissection with your middle finger than the index finger till the posteromedial aspect, and then harvest the tendon. Of course, you can save few, not all.
Probably placing the incision also obliquely
Oblique
rather
incisions
than
are
vertical
leading
one.
to less
Better exposure, and we are coming out with a study with that. Maybe next conference we'll present our
Yeah.
views.
Thank you, sir.
Question?
My question is very simple. Why we already know there are advantages of preparing the hamstring over the BPTB graft. Was there any other reason to choose the hamstring over the BPTB in your study population?
That's what we have said, that generally what is said is BPT graft is generally preferred for high sports active patients, and hamstring is generally for those older patients or those with patellar pain. This is what is the general outlook. I have not compared any study here with the BPT graft or the hamstring graft. I am just saying that hamstring graft can be preferred in Indian scenario, where people in the general population, 90% of the patient will not do any major sports activity or major activity levels as compared to the West. The West people are mainly inclined towards the sports activity, soccer, football and all. In Indian patient, this type of habit is very less. Even in our study, most of the female patients we had, maximum would do light jogging activity. In the daily living activities, they will never go for sports activities or heavy running or anything. And males also, after supposedly 25 years of age, they generally don't go for heavy sports activities. In that scenario, hamstring grafts can be preferred in Indian scenario.
I think that life of surgeon is also comfortable with the hamstring graft.
No pain.
Far more as compared to the BTB. So that's why paradigm has shifted towards the hamstring more.
In one of your slides, I have seen that you are using transtibial approach.
Yes, a transtibial approach.
Okay.
Thank you, Dr. Mukul.
Thank you, sir.
And Dr. Abhishek, you are here? Yes, please come ahead with your presentation of intra-articular distal radius fractures, arthroscopic assessment of fluoroscopy guided fixation and efficacy of various fixation devices.
Distal radius fractures, arthroscopic assessment of fluoroscopy guided fixation and efficacy of various fixation devices in maintaining high precision reduction. In the introduction, the distal, as you all know, the distal radius fractures are one of the most common fractures, accounting for up to 15% to 50% of all the emergency room fractures, with intra-articular extension being noted into up to 40% of cases. In the cases of extra-articular fractures, the close reduction techniques are very helpful and are suitable for the fracture management in a closed condition. However, as per previous studies, post-traumatic arthritis have been noted in cases with residual displacement of 2 millimeters in the articular step and the gap, which have been noted. Several authors have even incriminated displacements of even 1 millimeter in the wrist joint as causing long-term arthritis on follow-up. During fluoroscopy guided fixation, anatomical reduction of fractures can be visualized, but these are not accurately compared with arthroscopy. Has a means to directly assess the fracture reduction under the visual control. Previous studies have demonstrated the role of arthroscopy in the management of distal radius fractures and the correct delineation of articular step and the gap. We performed this study to arthroscopically revalidate the accuracy of fluoroscopy in fracture reduction. A near anatomical reduction of fracture surfaces of less than 1 millimeter displacement in both the articular step and the gap was attempted. And following this, when such high precision reduction was achieved, efficacy of various fixation devices in maintaining such high precision reduction was also noted. In this slide, the articular step in the pre-reduction X-ray is visible, and both the anterior, posterior, and the lateral views. However, in the after close reduction, in the OR under fluoroscopy guidance on the right side, the lateral view does not reveal to have any articular step or gap. This is on the left side is a pre-operative CT which shows a 2 millimeter of articular gap which is present, which on the arthroscopic assessment was also revealed to have an articular step of and a gap of more than 2 millimeters. We studied 20 patients of intra-articular distal radius fractures in the age group 18 to 50 years. Most of them were males, and the history usually denoted a high energy trauma preceding that. Pre-operative CT scans were obtained, and under anesthesia, the wrist was positioned in a shoulder abduction shoulder traction set with the shoulder in 90 degrees of abduction and the elbow at 90 degree flexion with the help of a Chinese finger traps. Arthroscopic assessment of the fracture was done. Following the provisional fixation and definitive provisional fixation with KYS, in some cases different fixation devices were employed as per the fracture characteristics to fix them, and after fixation post-operative CT scans were obtained. A look was also given onto the associated ligamentous injuries of the wrist. On the left side is a pre-operative pre-reduction fracture assessment by arthroscopy, which reveals that more than 2 millimeters of both the articular step and the gap, which is visible. And on the right side is a post-reduction which was maintained by KYS in this case after provisional reduction. We used a probe whose tip was 1 millimeter in width to assess the reduction step and gap, so that if the probe was able to enter the trough, it meant that the fractured gap was more than 1 millimeter, and similarly in the vertical direction we could assess the step also. And in the right side, since the probe is into the fracture and almost along the whole width, it is almost 2 millimeters, more than 2 millimeters of step and gap. On the left side is the fracture pattern preoperatively, and on the right side we had to use a distal radius plate along with a fixation involving KYS. This is a preoperative CT scan on the left side showing an articular step off, and compared with the postoperative CT scan where the plate and KYS are fixed to reduce the step off. In the results, most of the patients are male in the age group of 31 to 40 years with the right hand dominant side. The mode of trauma being the high energy trauma, road traffic accidents being the most common culprit. Unless alert fractures were associated in 12 cases out of the 20% cases. The fracture pattern as delineated by IOACON classification was more type C3, which included complex comminuted pattern in our study. Articular assessment was via fluoroscopy and arthroscopy were done. In the comparative study, the pre-reduction X-ray was shown to have an average step off of 1.85 and a gap of 1.86, which on better delineation of the CT scan was coming out to be 3.26 millimeters and 3.61 of step and gap. In the post-reduction X-ray and the fluoroscopy, 0.58 millimeters of step and gap were both of them less than 1 millimeters were visualized, which however on arthroscopic assessment came out to be more than 1 millimeter in both the cases. In the role of arthroscopy as delineated by this is the mean in the post-reduction radiographs on the fluoroscopy was 0.58 millimeters and 0.44 millimeters in the step and the gap. However, in the arthroscopic assessment it came out to be 1.86 and 1.50. After arthroscopic assessment of the fracture, we did a close reduction, and attempt was given with the help of probes and using the KYS as jockey to manipulate the fragments and achieve reduction. So after reduction, repeat assessment was done using arthroscopy, and for postoperative CT was done, where step and gap were coming out to be 1.04 and 0.96 millimeters. Of all the fixation modalities in both the voloplating by open reduction fixation and plating along with KYS, 50% of the cases achieve articular step reduction of less than 1 millimeter. However, in 9 cases with multiple KY fixation only, precise reduction was could be achieved only in one patient. External fixator was applied in only one patient in view of soft tissue swelling, and articular assessment could not be done. This is in the complications. The forearm swelling were ranging from minimal to moderate in intensity was noted in all the patients, which subsided on limb elevation. There is no evidence of any compartment syndrome. A single case of reflex sympathetic dystrophy was observed, and a delayed rupture of FPL flexor pulsus longus at 5 months post surgery was identified in one patient and was subsequently repaired. In the conclusions, the most common configuration fracture configuration in our study was type C3. And what we noted was it may always not be possible to achieve perfect reduction in such severely comminuted fractures, where there are more than 5 to 6 fragments. The relatively poor surgical outcome in our study is attributed to arthroscopic reduction of the fracture involving only a limited access to the fracture fragments on its radiocarpal articular surface. Since we performed the surgery after 4 to 5 days following trauma to allow the swelling to reduce, the organized fracture hematoma, which also tends to further hold the fracture fragments glued, smaller fracture fragments glued, and is not amenable to be dislodged and cleaned up from all around by arthroscopic means alone. In the take-home message, arthroscopy is a useful adjunct to distal radius fracture fixation, with or without assistance of fluoroscopy. None of the fractures demonstrating anatomical reduction on fluoroscopy was actually so, and as demonstrated by arthroscopy. Closed or open reduction under fluoroscopy, followed by arthroscopic reassessment, certainly improves upon the articular congruity and leads to better anatomical restoration in selected cases. We recommend that in cases with arthroscopically persistent step and gap of more than 1 millimeter, limited open or standard open measures may be an adjunct for accurate fracture reduction. Continuous traction may also be counterproductive in attempted anatomical reduction due to implied reduced mobility of the fragments due to ligamentous pull, and limited open or standard open reduction with fixation adds to the benefit of easy manipulation of fragments and reduction under diacrition.
Any questions? No questions. So I have to just comment that whatever you have done may be a good attempt, and for a die punch type of fracture fragment or for a very comminuted one,
yes,
whatever you do, even with the arthroscopy it would have been a difficult thing.
Yes.
And you have to, apart from the articular surface, you have to take care of the rest of the things as well, the overall alignment, the radial tilt, and whatever it is. So you have to be careful, and the position of doing wrist arthroscopy and doing the fixation, because we do the wrist arthroscopy in vertical position.
We removed the whole set, the Chinese finger transfer clean and drape.
I do understand that you change the position at the
Yes.
time of fixation and do the reassessment again doing the same thing.
Yes.
But working with so many tubes in a small joint is definitely, for the knee we do most of the time, but for the radius I don't think it's very common. So I think it's a good attempt, and maybe we have something better. But we all do understand that the lower end radius is something where even very bad looking fractures are having excellent functions. So maybe something overdoing or maybe useful. We don't say right now. Any questions? No? Thank you, Dr. Abhishek.
Yes.
Thank you very much. Dr. Abhijit, are you here? No. So we come to the end of the session. Thank you very much.
Thank you, presenters and audience.
So I welcome you all to this symposium on arthroscopy. Are all the speakers present in the hall? Dr. Acharya, and Dr. Dhananjay is there. Dr. Vikas Kapoor. Dr. Ashish Kumar. Dr. Ashish Kumar. Dr. Deepak Chaudhary and Dr. S.C. Goyal. So we have only 2 speakers at the moment. Should we start? Okay. So I welcome Dr. Acharya from Manipal, who will speak on is there a role of arthroscopy in osteoarthrosis of the knee, and this is a debate. He'll speak in favor, and then Dr. Dhananjay will speak against the motion.
Good afternoon, respected chairperson and colleagues. I bring greetings from the university town of Manipal. And my talk today is there a role of arthroscopy in osteoarthrosis of the knee? Obviously, I am talking in favor, so I have to say yes. This is a structure of my presentation: role of arthroscopy, indication, contraindication, literature support, personal experience followed by take-home message. The thought of cleaning the joint with the fluids started with the thought of lavage, where they were using needles to insert it into the joint, and plenty of fluid used to be passed into the joint. This was in the late 80s and early 90s. At the same time saw the advent of arthroscopy coming into orthopedic practice in a big way. So initially, whatever orthopedic surgeon could hold on was the patients with the osteoarthrosis, and whoever was comfortable with the lavage continued on to arthroscopic surgery. And in the initial stages, the aim of arthroscopic debridement was forgotten. The aim, realistic expectation would be to achieve decrease in pain and improvement of function. It is not a cure for arthritis. Arthroscopic lavage just pushed in fluids into the joint, whereas arthroscopic debridement as a procedure, as we understand it today, is visualization of the joint, use of sophisticated equipment, instruments to tackle the problems inside which are related to arthritis. So arthroscopic lavage is not equal or equivalent to arthroscopic debridement. Arthroscopic debridement, apart from visualization, tackles symptomatic meniscal tears. It prevents further progression of these tears, prevents further cartilage damage secondary to the meniscal tear. It also tackles patients' mechanical symptoms. There is a lot of literature support for whatever I am saying in these slides. In low-grade osteoarthrosis, tackling the painful synovium, tackling the painful plicae, removal of adhesions, and to some extent getting rid of the effusion are the beneficial effects of arthroscopic surgery. Loose bodies produce mechanical block, and they also hamper the function. So removal of loose bodies through the arthroscopic surgery improves patients' symptoms as well as improves the function. Anvil osteophyte is another specific condition which can be tackled with the arthroscopic surgery. Anvil osteophyte blocks the terminal extension of the patient's knee joint by physically blocking the extension. Late 1990s and 2000, the present decade has seen a lot of surgery done on the cartilage. It has also helped us to understand the cartilage and cartilage related lesions. And the studies which are done in these decades shown that those who have grade 1 and 2 cartilage injuries have an excellent result at the end of 4 to 6 years. The present day cartilage surgery include abrasion chondroplasty using shaver, radiofrequency coablation using specific wands which are temperature sensitive, doing microfractures for focal cartilage defects, which have led to increase in a significant improvement in function as detected by Lishom score, and also decrease in the VAS scores. Postulated mechanism of arthroscopic debridement works is by joint lavage, where there is dilution of degradative enzymes, removal of loose bodies and meniscal balancing, which take care of the mechanical symptoms, and then judicious use of chondroplasty help in prolonged life of the existing cartilage. The indications seem to be very specific. Acute onset arthritis with effusion, which was recently exacerbated with the trauma, imaging showing the presence of loose bodies, and specifically in early osteoarthrosis cases where there is no malalignment. Contraindications are those cases which are purely arthritic with deformity, decreased joint space. Earlier, the contraindications included age. However, recent two studies have shown that irrespective of the age, presence of the mechanical symptoms, in the presence of good cartilage on both the compartments, there is still a scope for arthroscopic surgery. Review of literature is contradictory, confusing because of the heterogeneous nature of presentation of patients and varied outcome measures in the literature. Most of the recent randomized control studies or meta-analysis suggest that there is a specific role for arthroscopic surgery in osteoarthrosis. 2012 and 2013 articles are meta-analysis as well as control studies are very clear on this stand, where patient selection is a key for your success and realistic expectation with respect to outcome is also important. The journal which is much talked about, the paper which is much talked about the arthroscopic surgeries done for arthroscopic debridement in 1990s, where every case with osteoarthrosis was subjected to arthroscopy. It was abused so much that 650,000 cases were arthroscopied just for osteoarthrosis in a single year in the USA. That led to various meta-analysis which analyzed that not every case of osteoarthrosis is for arthroscopic debridement. However, these papers also mentioned about a placebo effect for the patient. According to some, placebo benefit is still a benefit. If the patient is benefited by that, it's worth trying. Because patient presents to you with a subjective complaint, that is pain. Some of the papers or studies or meta-analysis seems to be driven from the industry of insurance, because most of the insurance papers insurance guidelines do not accept arthroscopic surgery purely for osteoarthrosis. However, insurance guidelines are very clear that in the presence of a symptomatic meniscal tear, presence of loose bodies, and to check for lateral compartment cartilage being intact if you are planning to do a corrective osteotomy like high tibial osteotomy. Personal experience with this regard is connected to the paper which was presented earlier in this session today, is arthroscopy followed by viscosupplementation. In that, arthroscopy definitely helped our patients. There were three subsets of patients, one managed conservatively, other with arthroscopic debridement, and the last one arthroscopic debridement followed by viscosupplementation. I would not dwell into the details of this study which has been told already. Patients who underwent arthroscopic surgery had good relief from their symptoms for 3 to 6 months. After that, the beneficial effects of arthroscopy started waning, whereas those who underwent arthroscopic surgery as well as viscosupplementation, the beneficial effects prolonged up to 1.5 years now. They are in the follow-up. The results will be publishing soon. Improved was decrease in the concomitant medication, improvement in the scores, knee scores is a beneficial effect of arthroscopic debridement. Predictors of good outcome for these patients is early X-ray stages, no axial malalignment, patient's weight, smoker or not. Take home message, arthroscopic debridement is best reserved for those patients with minimum radiological findings with no or mild malalignment. recent onset of symptoms less than 1 year, mechanical symptoms being present, presence of loose bodies, presence of unstable cartilage flaps, meniscal tears, impinging osteophytes. Most of the educational bodies, academic bodies agree on this. So the answer for the question is yes.
Thank you, Dr. Kiran. Please come and have a seat here. You want to sit there for the time because ultimately there will be questions. So I invite Dr. Dhananjay.
Honorable Chairperson, faculty, delegates. Well, no insurance company is definitely going to sanction the authorization for arthroscopy in an OA patient, perhaps because the patient is going to come up after 6 months again for another surgery that doesn't look like a good option for them. Anyway, this is based on, again, on my personal experience, and I have realized, I have burnt my fingers so often that I never to put a scope in a case of osteoarthritis as an arthroscopic intervention. What exactly we are looking at? Our objective from the patient as well as from surgeon's perspective remains a long-term relief in pain as well as improvement in the quality of life related to knee joint. So what exactly are we doing in arthroscopic management? As Dr. Acharya mentioned, such a long list of the things which could be done, which are being done as a part of treatment. And this particular article, which he also mentioned. So we are trying to understand why exactly this type of publications, they are coming into the picture. Perhaps there is something different with this disease per se. The natural history of osteoarthritis, it is something different, presenting itself in a different manner. We all know that the symptoms of joint disorders, they usually don't match with the pictures which you get in the MRI or in the X-ray. There's a strong mismatch over there. Hence, just merely correcting those chondral flaps or meniscal tears, we are not going to achieve, we are not going to alter the ultimate outcome of the disease process, and the patient is going to come back to you again and again with the persistence of the pain. The study done to appreciate what exactly is the cause in the persistence of pain in osteoarthritis. And they concluded that it's a subarticular bone attrition along with the bone marrow lesions which are responsible for the severe pain, which really incapacitate the patient to a great extent. Now, this clinical data made people to go for further more research. It was an animal lab study done on a rat joint just to find out how the subchondral bone lesion they can affect the outcome of the osteoarthritis. It was concluded that yes, if you are able to inhibit the subchondral bone lesions, you are able to alleviate the joint pain to a great extent. We talked about the meniscal tears. There's been so much of hue and cry being made. People say that perhaps if you don't treat a meniscal tear, it may lead to worsening of osteoarthritic symptoms as well as the disease. This study was done to find out the prevalence of meniscal tears in a certain population, and they concluded that yes, it's very common finding to have meniscal tear in asymptomatic patients. Number one. Number two, there is no relation between the cartilage volume or the cartilage loss or the cartilage lesion, but they were definitely able to associate the relationship between increase in the tibial plateau bone area, which was perhaps secondary to the osteoarthritis disease process that could have caused the meniscal tear. It was a level 1 study done at the Center of Arthritis Center at Boston, and they clearly said that you are likely to find, they were talking about grade 3 meniscal tears, not only grade 1 or 2. The MRI showed meniscal tears in 91% of the OA patients with the age of more than 45 years, and 76% had no symptoms whatsoever. So it's not the meniscal tear which are more painful. There is no reflection on the functional status of the patient. And they also suggested there is no role for the routine MRI in such cases. And let's not forget, these patients with the chronic pains, they are coming to you again and again with the persistence of the pain. And if you offer them something and they go for this short-term surgical procedure, they may end up with more pain and more discomfort, and they are likely to be cursing you throughout their life. There have been various publications about the role of arthroscopy per se in treating osteoarthritis. Most of them say it's a costly practice with limited and very specific indications. Outcomes, they may be as per the placebo effect, and there is no additional benefit apart from routine medical and the physical therapy which you can get. Even American Academy of Orthopedic Surgeons, they recommended against doing this procedure in the primary OA of the knees. As per the NICE guidelines, they also say please don't touch because the results, they are not good unless and until you have a locked knee. The Cochrane database has not been able to throw much light on this particular procedure. And as per our personal experience, that yes, the females 45 plus, you should be very, very wary of putting your scope inside such knees. There are so many psychological issues, hormonal imbalance, whatever. And in the Indian practice scenario, every procedure is counted. The patient is likely to come back and say, I've gone to his place, they took me into the operation theater once or twice. Even if you are going to give an intra-articular injection, you take the patient inside the operation theater, that is counted as one procedure. Regarding anesthesia risk, it remains the same, whether it's a half an hour procedure or 1 hour procedure. And second procedure, I mean, if first hasn't been able to deliver the goods, then the patient expects the surgeon to make the second procedure complementary for them. So in the end, I would like to conclude, arthroscopy has no role. If at all, you can go in as a treatment of the locked knee, then it should be termed as the arthroscopic intervention for the locked knee, not for the osteoarthritis. Thank you for your patient hearing.
Thank you, Dr. Dhananjay. Please come here and have a seat. Now we can have questions to both the speakers.
My question is to Dr. Dhananjay. As you showed in your slide that about 75% of grade 3 meniscal tears had actually no symptoms of knee pain. My question is for those patients with grade 3 meniscal tears who have pain and they also have coexisting osteoarthritis, grade 3, should we offer surgery, arthroscopic surgery to them? And I mean, how can we predict whether just by doing a meniscal resection, the pain will go and how to predict?
Yeah, I think it's a very clinical situation where you need to take a very, let's say, the decision is going to be quite difficult, I agree with you. So you just have to look at the grade of osteoarthritis. If let's say your patient is 50, 55 plus with grade 3 osteoarthritis, then perhaps I'd like to offer him high tibal osteotomy along with such arthroscopic intervention, otherwise no.
High tibal osteotomy for what? If there is no malalignment, still you offer high tibal osteotomy?
Grade 3 means there has been a decreased joint space on the medial side, yes.
So if there is a medial sided arthrosis, then you will do high tibal osteotomy. Okay.
As I said, isolated finding of grade 3 meniscal tear, no, I won't like to go in and operate. I would like to see other factors also.
I had a patient with a grade 3 meniscal tear, like you said, a 45-year-old lady with maybe a grade 1 OA changes. Did an arthroscopy, good relief for 2 months, but she came back with severe pain in the knee.
I tell you, I have burned my fingers so many times, you know. I'm very, very apprehensive of.
Okay, any other question?
But the results, you were saying with hyaluronic acid, you said that the results change. What is your experience regarding that? you give it at 3 weeks.
So this is to Dr. Kiran.
Dr. Kiran.
Yeah.
Yeah, we give it 3 weeks post-scopy.
So what is your experience? This is
your
the next
experience?
question.
Yeah, it prolongs the beneficial effect of arthroscopic surgery. And in most literature, the beneficial effect maximum lasts for 4 years. That again depends on what you found on arthroscopy, what grade of outer bridge, grading of cartilage status. Earlier stages do well, later stages effect lasts up to 2 years. Remember that when you are offering arthroscopic surgery, because patients are nowadays aware of total knee replacement, when you are offering arthroscopic surgery, you and patient should have realistic expectation. Means you will tell the patient that this is not an alternative for total knee replacement. You might eventually require it. Present, we are tackling the present problem. If that is a line of argument, line of discussion with the patient, there won't be any problems. When arthroscopy is sold as a tool to, as an alternative to TKR, then you are making a mistake. Never do that. In our study, yes. In our study, no trade names as what the organizers have told, Highland GF20.
Any other question? Yeah.
Have you done a second scopy of viscosupplementation knee to see the actual improvement in the scope?
Yeah, this is a very important question. Yeah.
Yeah. No, none of the viscosupplementation agents claim that they do the cartilage repair. They never claim. They claim that symptomatic relief they'll get. On an interesting note, we have done a couple of arthroscopies following viscosupplementation because patient came with some other problem. As I said, nothing extraordinary would be visible under the arthroscope.
So let me tell you, like we had a actually symposium in the workshop on viscosupplementation. We had a good discussion. As on today, there are no clear-cut evidence in the literature in sport or against viscosupplementation. Okay, so it's still a gray area. Yeah.
Even the last US recommendation, viscosupplementation is also not recommended.
No, they don't recommend. American Academy has neither not recommended nor recommended.
It is 2013 guidelines. In fact, he quoted 2010. I would tell you, they say that they don't say you don't give it. They say that this is not the first line of treatment, not recommended. That's all. It doesn't. You don't interpret it as not to be given. Same thing for glucosamine chondroitin sulfate. They say if the patient wants to take it, let him take. But we won't recommend, and insurance will not give it.
My question is not on viscosupplementation. I don't have to ask because
Yeah.
anything on what we say is delaying the TKR from symptoms, and we don't have anything delaying TKR. So if we can give the single shot of viscosupplementation without any evidence, what's harm? Okay, no evidence, agreed to it in doing arthroscopy. And again, this is just a delaying symptoms. You do arthroscopy, wash out, and what symptoms?
That's what my slides, I think, were very clear on that. If the placebo effect giving symptomatic
I
relief,
think this question will be better answered by Dhananjay.
Yeah.
Because he's yeah.
As said, initially we used to be quite aggressive in our suggestion of arthroscopic intervention, but later on we realized that it's not a good idea to see a couple of unhappy patients sitting outside your chamber. And as I said, in our country, the expectations from the surgery is quite high. People feel that once you have gone into the operation theater, you come out, there should not be any problem whatsoever. So fine, if the patient comes to us, we look at the X-ray, if we feel this is typical osteoarthritis, grade 3+, if the patient is willing for surgery, but wants some time, we'll give them intra-articular steroid. Fine, it will give you 1 month, 2 months, that's it, nothing beyond that. If the patient wants 6 months plus time, then we like to give them this particular injection, supplementation. And if in between cases, grade 1, grade 2, we simply put them on long-term physiotherapy. Let them go to someone else, get the arthroscopy done, and fine, if they...
I do not have seen any rental patient outside after having high cost viscosupplementation. I'm from a relatively
not working in the metro. So I've also seen patients who have spent a lot of money sitting outside my chamber and not feeling very happy.
Yeah, that's a common practice. I come from a medical college. So this is in Chandigarh. People have a paying capacity also, but they are very wise people. So they actually really want to know that it didn't work. So it's a very unpredictable.
I would only say that patient selection is the most important for any non-operative modality of treatment. We know that the endpoint arthritis, there is no discussion. It has to undergo arthroplasty. We are only discussing about the sequence before that. You should be very
I think this
clearly
topic
telling
is well discussed. We wind up the symposium now. Yeah, there is one more question.
How frequently you put the cycle of arthroscopy, debridement and visco supplementation? And the last, when you to tell no to the patient?
These procedures are one-time procedures. Arthroscopic debridement is indicated in osteoarthrosis in a special situation when the patient has a mechanical symptom. The symptoms don't subside after your initial therapy. He is for total knee replacement or arthroplasty. There is no cycles for this.
Now what about viscosupplementation? You want to repeat the injection?
Viscosupplementation, the patient who is benefited first, if he comes back with minor symptoms, you can always repeat. An average month of repeating is about 19 months.
Actually, different preparations have different duration of their half-life. So that is recommended by the manufacturer. So we end up just by binding remarks that I do lot of arthroscopy myself also. So I will say it's neither yes nor no. So please select your patients well. A patient who is relatively young, who has sudden exacerbation of the symptoms, he had been sitting on the floor, he had been going and running around, X-ray shows marked changes of osteoarthrosis, I would definitely give him a option of arthroscopic debridement and will also tell him that if it doesn't work, then you have to go for total knee replacement, because total knee replacement does not give a normal knee joint. Patient has some limitations, as all of us know. So thank you very much, and I invite the next speaker, Dr. Ashish from Lucknow, meeting you after a long time, and greetings.
Good afternoon, and I am going to speak towards single bundle anatomical ACL reconstruction. The procedure we all are doing. Whatever I am talking, that is based on the literature, and basically it is on the anatomical medial portal reconstruction, not the transtibial. So what I have to say that we go with the law of averages, that Indian population has got an average built with the average size of the footprints of the ACL, and average thickness of the semitendinosus, we find it is rather thin, and if we talk about the gracilus, then God knows it's very weak. So average demand of the patient, that's the good part, that most of the people are less demanding in our country. Average affordability, rather poor affordability, that's a problem. We have to consider everything about the implant and the procedure. The average training and skill of the arthroscopic surgeon is also important when we talk about the single bundle or the double bundle, and the setups which are available throughout the country, they are not very high quality everywhere, and the inclination of people towards sports is relatively less. So that's the good part for the arthroscopic surgeons. And when we do the arthroscopy, many times we are not able to appreciate the two bundles separately, the more said than felt. The small Indian knees, especially females with narrow femoral notch, difficult to work with them. Weak hamstrings are available. Even if we make it quadruple, it hardly goes for a 7 millimeter, although we need 8 millimeter. Then we have to cut it and make it 8 strand or 6 strand, something like that. So by doing a double bundle, we are converting one reasonable graft to two weak grafts. That's the logic. And moreover, as the graft is thin, it is difficult to be fixed it tends to slip away. And if you try to make it more strong screws and everything, then it overstuffs the notch, That's the other problem that we face with the double bundle reconstruction. So, procuring somehow, if you make too strong graft, may take from other knee, or you have the allograft which is not available all the time, impingement of the notch anteriorly by the anteromedial bundle, and the posterolateral leads to impingement over the PCL. That's the problem if you do with the double bundle technique. So, it is from the literature that most double bundle studies indicate a more vertical placement of the anteromedial femoral tunnel and a medial placement of the AM tibial tunnel. So, the PL bundle is pressing over the PCL and the anteromedial that stretches out in the flexion. There is a problem many times. The small footprints, if they are less than 12 millimeter apart, there is no sense of doing double bundle, and many of our patients fit into this category. So, the two bundles, even if done, they are effectively one single bundle in the small knees. And if you do a single bundle properly anatomically placed, it functions as does a double bundle reconstruction with different fibers in the single bundle. This is the basic logic of doing the single bundle reconstruction. And most of the ACL injuries we encounter are non-sport injuries in our country, and patients are less demanding and they just want to be back to work, not to the sports. That's the basic thing. Double bundle is more talked about the better fitness to go back to the previous status of the sports in the Western literature. So, anatomical single bundle reconstruction is a time-tested procedure to fulfill these requirements of our patients. Cost of the implant is very important in our country. It doubles up as you make the bundles double. The cost of procedure increases as the duration of surgery, the OT time raises, latest fancy procedure you are doing and the latest surgeon doing the procedure, so you have to charge relatively better if you do a double bundle. So, nothing to say if you are thinking about the allograft. So, cost is again very important. If we talk about the average Indian arthroscopist, there is mushrooming of the people who are doing arthroscopy, nothing wrong into it, but of course going for a procedure which is difficult with a steep learning curve, that is a problem. So, average quality of setups are there, and limited training may be sufficient enough to perform time-tested single bundle reconstruction, which is rather easier procedure rather than doing disastrous double bundle. So, more demanding, which is, and with a steep learning curve. So, in double bundle, duration of surgery is more, regaining range of motion is relatively difficult because anteriorly it is impinging in extension and posteriorly in gaining the flexion. And it is proven by the studies that regaining extension is a problem with a double bundle. Then, if double bundle fails, then what to do? You are going for any non-anatomical option, something like that. If both tunnels colliseate, then you have a large single tunnel. It's difficult to manage. So, there are concern that especially on the tibial side, when you drill two tunnels, there is a very weak and little bone left over between the tunnels, and that creates a problem in the graft fixation. When we talk about the knee functional outcome scores, practically there is no difference. I have placed studies later on in my presentation where you can see there is hardly any difference. The much talked better control of pivot shift phenomena is only proved in vitro, not in the real life or back to the sports, back to work. It is proven by certain studies which is at the end of this. So, for all practical purposes, double bundle reconstruction is something which is to be reserved in very expert hands. And here again from literature that it is difficult to say that anything is better if we talk about the double bundle. And if we talk about the revision surgery, that's again a problem. You have so many tunnels there and you have to place graft first and reconstruct the structure and then go for the revision. So, two surgeries in two stages, again think about where the cost goes. So, we can summarize that anatomical single bundle reconstruction is a reliable, time-tested, less demanding, cost-effective procedure suited in Indian scenario, whereas double bundle is still a concept and not a proven entity. I have not mentioned that when you do a double bundle, you are removing whole of the footprint, whole of the ACL stump, so proprioception may be a problem, and making these tunnels you can produce the osteochondritis of the femoral condyles. So, these are the other things. So, these are a few studies which show that double bundle reconstruction of the ACL did not improve function or stability compared with the single bundle reconstruction, or it did not detect any significant differences in subjective outcome measures, and no significant difference between single bundle and double bundle reconstruction techniques, no clinically significant differences. So if literature is not supporting, and it's more difficult procedure, and we don't think that there's any reason to do it for the reasons I have.
At that time, people were doing transtibial technique, where the graft was going very vertical, and there were significant number of patients who were not getting full benefit. But after the double bundle technique, now there is an anatomical reconstruction of the ACL, where we are going actually in between the two bundles on the femoral side. So the results in terms of objective assessment, even the originator of this double bundle technique, Freddie Few, objectively he has shown that by machine the testing reports are better by KT 1000, KT 2000. But when it comes in terms of functional scores, it is the same as compared to the anatomical reconstruction, now what we are doing. So this is what I wanted to add in, like, for double bundle reconstruction. Now open for the questions.
Initially, everybody used to do conventional transtibial reconstruction. Now, most of the people have switched to anatomical basic reconstruction. Do you find any difference in clinical results in our scenario? Because most of the persons are not sportsmen. So, do you find any difference in results when doing routine activities between conventional transtibial and anatomical